right, Wes. Well, I guess we'll go ahead and get started.
Okay, I'll transfer you now.
Thank you.
Excuse me. You're welcome. I'll transfer you now. During this transition, you will hear silence, some beeping, and then my introduction. And Deb, excuse me, I'll turn the floor over to you first.
Thank you very much.
You're welcome. Transferring now. Good afternoon, ladies and gentlemen, and thank you for waiting. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Deb Smith. Ms. Smith, the floor is yours.
Thank you, Wes. Good afternoon, everybody, and on behalf of VHQC, I'd like to welcome you to the September VHQC HAI Improvement Network Sharing Call. Thank you. Here we go. So just a little bit of call etiquette to start out with. I really hope that everybody is present and attentive to this call. It's just an hour, but that being said, I know that an hour out of a busy schedule is quite a long time. If you do have to take any phone calls or leave the office or somebody comes in your office, feel free to hang up and call back. That's always an option. But I'd like to remind everybody right off the bat to please mute your lines when you're not talking. Since this is a sharing call and we really want to encourage sharing, this is a completely open call. There are no muted lines, so we have to be responsible for muting our own line. And somebody right now is coughing and their line is not muted. So just kind of be aware of that. Also, come prepared to share. Being a sharing call, what we're really encouraging and hoping will happen throughout the next 4 years is that this is going to be just like us meeting in a meeting room. Everything's virtual and we're doing everything on a teleconference now. But it would be nice if we can have conversation and be able to talk to each other about what we're finding with HAI prevention that's successful, what the barriers are, where we need more work. We're trying to concentrate on patient-family engagement, so if there's something that you're doing with that, we want to hear about that. Any articles or research or breaking news that you'd like to share with the group, this is the place to do it. So I'd like to welcome everybody that's on the call. Our patient advocate, Claudia Davis, who many of you have met virtually through the last call, was not able to be with us today. So she'll be attending the next call, hopefully. All the Maryland and Virginia Improvement Network providers that are on the line today, we have quite a few Maryland and Virginia stakeholders on the line also, so we'd like to welcome everybody. And then, of course, our team at VHQC, my name's Deb Smith. I'm the Improvement Consultant for Virginia. Carol Whalen is on the line, who is the Improvement Consultant for Maryland. Rhonda Fletcher is our project assistant at the VHQC office. Annie Radowski is the manager of communications. And this is our call, all of our calls, so participation is encouraged. We'll take care of welcome and introductions as VHQC, and then we're asking for some help with chat monitor and time monitor. Rhonda has agreed to be the time monitor again. And then today we have Diane Jones, who is the Director of Infection Prevention for Centra in Virginia, will be our chat monitor. So welcome and thank you very much, Diane.
Hey, Deb. This
Yes.
is Carol. And hello, everyone. I'm getting some feedback echo on my phone line. I just wondered if anybody else is, if there's anything we can do about that.
Wes or Jennifer from WebEx? Is everybody muted that needs to be muted? Did it go away?
I'm getting the same echo, but it seems like it might be better.
Yeah, I think it went away.
I think it went away.
Let us know in chat if you can hear us okay and if you're still hearing the echo. All right. Okay, it's better. Awesome. So we do have a project update. On our last sharing call, we did ask for a name suggestion for the Maryland, Virginia HAI Improvement Network, which is way too long to say, way too long to write. So we had one suggestion come through. We asked y'all to share it either by email to us or on the online community. And this suggestion actually came through the online community from Ginny Crouch, who's infection prevention for Sir William Franklin Hospital in Virginia. And her suggestion was MCHIN and then pronouncing it movin'. So we'd like to know, if anybody else has a suggestion or what you think about this one. So type in chat, or does somebody want to speak up and give us another name, maybe? Yeah, I think it's pretty cool too. When she typed it in, I thought, oh, that's neat, because I had played around with these letters, couldn't come up with anything, but I'm not all that terribly creative. All right, well, this is probably what we'll go with then. So thank you, Ginny. We're moving.
So, Deb, if we get an email or if we get some communication that has moving on it, then we just know that we're talking about the Maryland, Virginia HAI Improvement Network, right?
Right, and maybe we'll get with our communications department and see if we can't come up with a nice little logo that goes with it, too. But that's exciting.
Oh, that would be awesome.
Yeah, that would be fun, wouldn't it? All right, so, oh, man, this must have been about 3 sharing calls ago that we actually introduced this Partnering to Heal video and asked everybody to watch it. It's a 6-minute video. With everything else that was going on in our calls, we kept running out of time, so we put this right in the beginning of this call because we really do feel that it's important to have a suggestion about this. So that being said, I hope everybody's had a chance to watch it.
Hey, Deb,
yes.
Could we ask everybody, if you did watch it, would you just type a Y in the chat box? And if you didn't, type it in. That way we can kind of see what kind of response we got to watching the video. Thank you.
Great idea. Thank you. And then we'd like to have some discussion about it. So when you signed in, this is what you saw with that video, and you had the 6-minute introduction. And then if you went any further, you could actually pick one of these characters. So you had the family member, the physician, the infection preventionist, the resident, the nurse. You could pick any one of those roles to see how you could have prevented this from happening. I just took a couple of the pictures from it just to kind of jog our memory, but I'd like to hear from people in the group how you used it, how you felt after you viewed it, if you plan to use it in the future. So I'm going to call out Linda Sokos because it looks like you have used it. Are you on mute, Linda?
Deb?
Yes.
Can you hear me?
Yes.
Oh, okay. I'm sorry. We have been using it at Danville for several years. We use that introduction video. I think it's one of the most powerful videos I've ever seen to show in a very real way how infections can be spread so easily. And the feedback that I get every single time I show it is awesome. And almost in every orientation, somebody is brought to tears after watching that video. So I'm all for it. I think it's great. Now, I've watched some of the different scenarios that take the roles of the other healthcare providers, but I've never used that in any of the, in anything at Danville, but I think it would be useful.
Thanks. Yeah. That's nice feedback to have, too.
Linda, this is Carol. I have a question for you. So when you say you used it at Danville, what
What groups do you show it to typically?
We use it in every new employee orientation. So every 2 weeks, a group of anywhere from, say, 5 to 20 will see that video, so that probably the majority of the employees there have seen the video.
Oh, very good.
I've also used it for residents as well.
Oh, that's even better. So do you guys use it for annual education at all?
Not for annual. What I typically have done is I do my little spiel for infection prevention orientation, and then at the very end I show that video, and I always preface it by saying, if everybody watch this, you wouldn't need to listen, you wouldn't need to hear me, and you wouldn't need me, because everybody would do the right thing every time, and it's usually very powerful.
So somebody else in the group that wants to either ask Linda how she got that going, or if you've used it yourself.
So this is Anna Sellers from Pennsylvania Regional, and I'm using it in the same way Linda does. I've been showing it to the general orientation, so it's all clinical and non-clinical who see the video.
Thank you. So has anybody used anything further than just the first 6-minute video?
Deb?
Yes.
This is Teresa with South Regional.
Hi, Teresa.
Hey, we were talking about incorporating it into our patient safety coach. We have meetings like once a month.
Oh, that's a good idea.
And so, because I showed this at the department management meeting it's been about 2 years, and I show it in clinical orientation and critical care course and the new hires. So, and they were pretty impressed with it too. It does leave a very impactful.
Yeah, because my feeling is we've all seen some of these breaks in infection prevention. We've all seen it. So it's quite possible that this can happen in your hospital.
Right, and the patient safety coach meetings that we hold, we had one several weeks ago on hand hygiene, infractions that they found. And when they saw the video, it just a lot of people commented on, I didn't think about that scenario or what was going on in that scenario. And so that's why they were talking about incorporating the other modules.
Right.
Because then they can use those as like a peer review kind of thing.
And it is really easy to incorporate those modules. I know when I was an infection preventionist at Martinsville, we used the nursing module for the new nursing hires. And it's something that, you've got this feedback that's going on right then and there, discussing it in a group. So it works really well.
Right.
This group that you have, how long have you had the Patient Family Advisors group?
It's the patient safety coach. It's part of community care.
Oh, okay.
It's kind of in alignment with the student group. And it's speak up with peer coaching, any infractions that you see with like hand hygiene, medication safety, just any kind of event that can occur in a hospital.
Okay.
Patient safety coaches awareness. And so they have meetings at night and during the day for participation, and it's encouraged to have one participant from each area, within the hospital, not just the clinical portion. But since we've had this, it's been really enlightening because I have gotten overwhelmed with calls and inundated with a lot of calls, which is good because people are speaking up. And we also, if they find any infractions, they peer coach the person that they find the infraction and put it in the ERS system. So it's pretty involved. And so this would be a good opportunity for them to see how it would turn out if they use each individual person within the video to see how the outcome would be.
Right.
Because sometimes you can't see it, and maybe it'll facilitate a better, alliance with the healthcare people that they have to, ask questions, redirect them to the proper way of doing things.
Well, thanks. Thanks for sharing that.
Oh, you're welcome. It hasn't started yet, but we were just talking about it like 2 weeks ago.
Yeah. It's something that, other hospitals could probably get in on, and maybe there's some of you out there that are already doing that. Anybody else that's using it like that?
I was curious if anybody's using it with their leadership. I think the introduction video is highly impactful with the leadership board starting it off.
So I did it at the department managers meeting.
Oh, good.
Yeah, I did that 2 years ago. So that was impactful.
So anyone else out there that's using it? Thank you, Teresa.
You're welcome.
Looks like Debbie Maliarakis. Do you want to talk about how you're using it?
Hi, this is Debbie from Inman Hospital.
Hi, Debbie.
I used it not ongoing, but I have used it in the past for special education training, like someone said, with the managers and leadership. It's very impactful. I haven't used it recently. I would love to use it at more time during general orientation, but I think we all find that we're kind of restricted on our time. But it was very good. Everyone really liked it.
Thank you. Yeah, I know, other than restricted on time, I know when I first sent it out, I think this has been out there a couple years, like maybe 4 or 5, I don't remember when it first came out, but I sent it out and in the hospital, and then staff tried to access it. Well, it quickly eats up bandwidth. So I will give you a warning that you might want to be careful, especially in some of the smaller hospitals that have limited bandwidth, that this isn't something that you want everybody pulling up at one time. Don't know if anybody else came up against that or not.
I think we have some Maryland hospitals that have viewed the video. We'd love to hear from any of you guys how you might plan to use it if you've not used it before, or what you thought about it, or if maybe you're using something different or similar.
It's so hard to be on the line and not talk. But we do want to encourage everybody to share. This is Deb again. If there's anything that you think you're going to be using, or anything that you gained from this, we'd love to hear from you, even if it's later on, in the call, or finish it up in the chat box here. But thanks to everybody who watched this. I think it pretty much speaks to the work that we're all really passionate about.
And Deb, I think I'll continue the discussion on our online community after the call.
Oh, good idea.
If you have any comments or anything you want to say about it, you can, if you're out there on the community, you can drop a line or two in there. We'd appreciate that too. Others will be looking at it.
Deb, before we leave this time, I just wanted to share there was a question about disseminating that video. It is open to any hospital, not just those in the network. Is that correct?
Oh, thank you, Diane. Yes, it is. I thought we had, hang on, let me go up to the previous slide. There's the website for it, and we had sent it out. It's probably in the agenda that got sent out today, and it's also on the online community. But this is in the Partnering to Heal. This is open to everybody. Yes.
Right. Deb, sorry to say it's not in the agenda today.
Oh, it wasn't? Okay.
But I did post it in the chat box.
Okay, wonderful.
So the link is in the chat box if you need it.
Well, there you go. Yes, share it. And, because I misunderstood what Teresa said, but this also would be good for, we're trying to get patient family advocates and to get a patient family council up and going. This would be something good to share with them, too. For anybody that's out there that's, doing anything with patient family engagement, share it with them, not just staff.
One thing I thought was neat about it is that, and maybe just, we can move on, but it's been difficult to find patient stories like this that are related to infections. And so I thought this one was especially meaningful in that it's very direct about hospital-associated infections and events. So there's not a whole lot out there, and I thought this one was just really great about that.
Yes, I agree. Thank you. All right, well, if there's no more discussion on that, we're going to move on to our stakeholder updates. We do want to hear from the stakeholders. We want to know what's going on in Maryland and Virginia with HAI prevention. So that being said, is there anybody on the line today from the Maryland Department of Health and Mental Hygiene? And I will tell you that we got there's a lot of people on vacation right now. Coming back right after a holiday like this, first day back, is a little difficult, and maybe in hindsight we should have changed the meeting, but it's also good to keep it that you always know what, second Tuesday of the month, so we chose not to. So Maryland Cost Care Commission.
This is Eileen Witherspoon. I just had a
Hello, Eileen.
Hi, how are you?
Good.
We had audited, had done more of an internal audit this year for calendar year 2014 HAI data, and we're going to be sharing that soon in a webinar with the hospitals and our plans for next year. So I just wanted to share that, but that was about it for right now.
Oh, thank you. Well, that'll be really interesting. I hope that you do share that webinar with us, too. I'd be interested in that.
Yep, definitely.
Thank you. The Maryland Hospital Association?
Hey, Deb, I don't see anybody in the attendee list from the Maryland Hospital Association, but I just wanted to remind everyone that they are partnering with the Patient Safety Center on a sepsis project. So all of that is on the website, and if you're interested in any of that support or anything that group is doing, there's also a list of the hospitals that are participating in that work, so that might be a good resource for you.
Thank you. So the Virginia Department of Health?
Hi, everyone. This is Andrea Alvarez.
Hi, Andrea. Thanks for joining us.
You're welcome. I'm the HAI and flu coordinator here at the State Health Department. Wanted to mention to the Virginia IPs on the line that last Friday I sent some information about our upcoming state HAI reporting regulation changes. Later this week on Thursday at noon, we'll be having a webinar, or really a conference call, listen only, to talk about what these changes to the state reporting regulations mean. And the bottom line is that our state reporting regulations will align our state reporting requirements with what hospitals are already reporting into NHSN for the Centers for Medicare and Medicaid Services Hospital Inpatient Quality Reporting Program. So with that email I sent on Friday, there were two attachments, one about conferring rights and kind of walking through some of the parts of the template, and then a frequently asked questions document. So please refer to that email for information on that conference call on Thursday if you want to listen in and hear a bit more. And if you didn't get that email or if you have other questions, feel free to contact me directly and we can chat more offline.
Well, that was a long time coming.
Yes.
But I'm really glad that it is. Does anybody have any questions about that right now? We'll send that out also, just in case somebody didn't get it, but I'm sure you have the same contacts. But it'll be a reminder.
Okay, thanks, Deb.
Yeah. Anything else?
That's all for now.
All right. Virginia APIC.
Hello, Sonia Jones. I'm also serving as co-chair for our education committee. Is Marsha Camp? I don't think she's on, but our folks at Carillion are chairing that this year. Betsy or Beverly, either one of you would like to speak to the education conference we're having next month?
Diane, this is Betsy.
Hi, Betsy.
The last I talked to Beverly, we only had maybe 40-something folks signed up, or registered, I should say. We're still trying to collect items for silent auction so we can provide scholarships for those attending for next year. But otherwise, all the speakers are lined up and everything's ready to go.
At our conference this year, the title of it is "We're All in This Together." Now, isn't that true?
And it's in Richmond. I'm sorry, Richmond, Virginia.
And the date again?
Okay, we have the pre-conference is October the 15th, but the actual conference is at Friday, October the 16th. And registration is still open. If you go to www.redonline.com. APIC Virginia 2015, we've got some dynamic speakers this year. We're going to be talking about emerging pathogens and long-term care setting as well as the ambulatory care setting, isolation related to MRSA colonization, actually not using contact precautions, research for the novice, and the hot topic of the ERCP scopes. We have Dr. Bailey's going to share with that, as well as Ebola update from Dr. Gleason, who I believe she's actually spent time in West Africa on that. And we've also submitted for 5 contact hours, so we're looking to have that available. So we're waiting on that approval. So if anyone has not registered or if you're interested, we would love to have you to join us.
And you do not have to be an APIC Virginia member, correct?
Oh, that is correct, absolutely. So registration and Reg Online, and you'll be able to register as well. Whoever will.
Can one of you please put that access into the chat? So anybody who is out there that wants to just copy it can take it. I know I always feel like I'm missing something if I didn't get to the Virginia APIC conference, so it's always a great conference. I'm sure it will be this year. And I'm going to call on Linda Soltos again. Can you just do a brief update on the pre-conference?
Sure. Every year we do try to hold a pre-conference the day prior to the educational conference, where we have, I think, a pretty awesome faculty. Deb Smith is one of those individuals. It's Deb Smith, Linda Adcock, Benita Allen, this year Teresa Stowasser is joining us, and myself. And we spend a full day reviewing for those individuals who are preparing for the CIVIC exam, the CIC certification exam. It's a packed day. Obviously, we can't cover everything, but we have reformatted it this year to align with the new exam format. And we finish it up with a little mock exam, and it's usually about 25 to 30 questions, and we have opportunity to discuss the answers to those questions before the end of the day. Last time I checked, we only had about 4 people registered. We usually have about 30 in the class. It was a little bit early, but anyway, we welcome any and all. We have alternated with what we call nuts and bolts, where we tried to gear that towards the new practitioner, and then every other year having the pre-certification review, but there haven't been a lot of new IPs, so we pretty much stick with the certification, pre-certification format for the person who has been working in infection prevention for a little while.
Well, thank you, Linda.
Sure.
All right, anything else from Virginia APIC? So we'll move on to the Virginia Hospital and Healthcare Association, VHHA. Jan, are you on the...
Yes. Hi, Deb and
Hi,
everyone. It's so nice to still be around and to be participating in these calls. Just a couple of things to mention from the VHHA side. We concluded the HRET County House ICU Cohort 9 back in August, and if you recall, we had 24 hospitals with 27 units participating in that cohort, and we're waiting to hear from HRET for the final press release. We're not allowed to officially release any results yet until we get the final, data analysis and press release information, but it's due this month. And once that comes out, we'll be able to officially release to the public and to other stakeholders, how things went with the collaborative. But I think in general, I can tell you that it was a really vibrant and robust cohort. It was especially exciting for us to partner with the Society for Critical Care Medicine, who provided a clinical nurse and a physician team leader to work with our hospitals that were involved in this cohort. And that really just added, I think, a really great dimension and brought more physician engagement into this project, more than I have seen in others. So that was really exciting. So more will come on that, and we hope to be able to share the results of that cohort before the end of the month. The second item is that we did apply for funding through CMS to participate in round 2 of the Hospital Engagement Network. We're calling it HEN 2.0 affectionately. So we've spent the last few weeks reaching out to hospitals that have expressed interest in working with us again with this round of HEN work. And the big change, I think one of the biggest changes that we can share at this time is that instead of partnering with North Carolina, we will be partnering with the Health Research and Education Trust of the AHHA, also known as HRET to many of you. That partnership just will bring a lot of national content experts and resources and just other contacts to the table and broaden what we will be able to offer our hospitals here in Virginia. So we're just waiting for the go word from CMS on that, and we're positioned to launch as soon as that go is received. And finally, I would like to introduce Betsy Cole to the group. Betsy is new to the VHHA and is working with us on our quality and patient safety team. Betsy joined us as a performance improvement specialist. Betsy, are you on the line?
Yes, ma'am. Hi, everybody.
Hi, Betsy. Welcome.
Thank you.
And so I'm glad that you all brought up about Virginia APIC, and we'll see what we can do about getting some VHHA representatives to that conference. So thanks for reminding us about that. And I think that's it for now. We're just kind of waiting for the big button to push, and then we'll be moving forward with our HEN work, for which HAIs will again be another major group of target improvements in that work.
Well, thank you, Jan. And we look forward to, working with the VHHA with the HEN work again, like we did in the last HEN, I guess that was HEN 1.0.
Yes, that makes sense, doesn't it?
And Betsy, we're excited to be working with you too. Thank you. And then also, thank you, VHHA, Jan, for letting our providers view the content calls for the Patty Cusp that just ended. That was really a great opportunity for the rest of our providers who were not already signed up for the cohort. So we appreciate that. And if you would like some time on the next call to give us some of the updates of that cohort, we'd love to hear about it.
Absolutely. And Deb, you raised a really good point that I would like to emphasize to the hospitals that are on the line, particularly the ones from Virginia, in that we have really tried through our work, particularly not only with the last HEN, but as we go forward with HEN 2.0, to collaborate with the other stakeholders and VHQC. We know that many of you are participating in specific collaboratives with other organizations like yours and this network. And so we try very hard to collaborate and to partner in our work so that it minimizes the time commitment that we are asking of our hospitals. And we will strive to do that in HEN 2.0 again.
Yes, thank you. And, of course, anything that benefits one part of this network benefits it all, so it's all useful for both Maryland and Virginia providers.
Absolutely. Okay.
Well, thank you, everyone. Is there any other stakeholders out there that would like to jump in here? So I would like to remind everybody to please keep their phones on mute. We are hearing some background office-type noise, doors and things, so make sure your phones are on mute. And I'm sorry, was somebody? Yes.
Yeah, it was me. I just thought if I had some canned applause or anything like that right now, I would probably play it for all of our stakeholders. What a great update we had today. Thank you, everyone.
Yay. Yes, thank you. All right. Well, moving along in our agenda, the next thing we wanted to talk about was the TAUDI TAP, Targeted Assessment for Prevention Strategy. This is a CDC strategy. It's out there actually through NHSN now. We have reports, TAP reports, and there is for TAUDI an assessment tool that VHQC will be using for the TAUDI work moving forward with the network. But we just kind of wanted to briefly go over what this was. You can see here on this slide there's two really great website connections here that you can go to, try out these links and see everything that's on there. I mean, it would take days to go through everything. We just kind of wanted to do a brief update on this and what it is. It's a method that's been developed by the CDC, and it uses data for action to prevent HAIs. It targets the healthcare facilities and actually down to specific units within those facilities that have a higher burden of HAIs. So this gives you a chance to actually see where to target your prevention strategies in your hospitals. I started creating my own slides, and I went onto that website, and who better than Carolyn Gould and Maggie Dudek to actually let us know what this is. And these are the training slides from the February NHSN training in Atlanta. So I just pulled these slides off to use today to get this discussion started. The objectives of the webinar that they gave were to describe the TAP strategy, review the calculations, and illustrate TAP reports that can be generated. And they explained that the TAP strategy is to target, assess, and implement. So you're targeting the facilities using that TAP report that ranks the facilities and then the units within those facilities. And you can assess the gaps in your infection prevention program using the facility assessment tools, which the one that we're using is a TAUDI baseline assessment. In doing our onboarding calls, which, have just gotten started, so there's been a few of you out there in Virginia and Maryland who have had onboarding calls, And those of you in Virginia have suffered through me trying to do these calls as a teleconference using Skype for Business, which I promise you at some point I am going to be very proficient in. But at this time, thank you to everybody who has helped me kind of limp along with that. But we're introducing that assessment on these calls. And moving forward, everybody's going to have an onboarding call, and we'll have a better chance of talking about it one-on-one. But then there's also implementation guidance on the CDC website that best practices and what you can do once you've assessed your areas that need improvement. The coolest thing about the TAP program is the CAD. This is the cumulative attributable difference, and this is a calculation of the observed minus the predicted, and it's actually calculated using different targets, whether it's the HHS target or the national SIR, or moving forward at some point we're going to be able to use our yearly targets to see where our facilities are. So basically, if you have a positive CAD, so that means you have excess infections. If you have a negative CAD, that means you have fewer infections. This is just a little illustration about how they come up with the CAD. So, of course, they calculate what your predicted is, you have your observed, and the difference of that is your CAD. I had some samples, some screenshots and samples of the facility level reports. So on this report, you can see there where to the very left is the facility ranking. So when we pull reports as VHQC, we can pull these reports using all of our network providers, so all of the hospitals who have signed up with VHQC. And they would be ranked. And one is not the place that you're striving to be, but, you know, there always has to be somebody who's number one. But that number one facility, as you can see there on this example, has 22 excess infections, almost 23 total. And anybody that has any questions during this, I mean, this is just a really brief overview so that we have something to start our conversations with while we're doing our onboarding call. But type it into chat or stop me. Is there any questions at this point? I think anybody that went to national, they did a really good job, from what I hear, of introducing this.
Hey, Deb, I think this is a good place for us to talk about the conversation that you and I had when we were looking at this, because when I was looking at the definition of the SIR and looking at the CAD, they both seemed so familiar. And so I thought it was, after we talked through it a bit, understanding that the CAD is actually the difference. It's the calculation number of the difference. So I thought that was a good conversation that I thought I would share with the group.
Yeah, I think it's going to be easier to explain the CAD, especially to leadership, because the SIR has been very difficult to really get going, and from what I've seen, it hasn't been accepted as well especially by leaders who aren't using it daily. But it's going to be pretty easy to explain that you're over by 23 infections as to what you've been predicted to be over. If there's a better number to it. But even better is the way these reports go down into a rank of your units. So it would be pretty easy once we get started here to see which units within your facility are the ones that you need to spend the most time on to begin with. This facility here that's ranked number one, they have locations 1073 and 11001 that both have 6.2 overage, excess infections. So, of course, with a facility like this, we would start work on those units. And when you look back here, because you actually know how large it's not in this one, it must be moving forward. the reports pull in the annual survey, the rate tables, the SIRs, and any event level information for cloudy and cloudsy, but only for those areas where a corresponding denominator is being reported. So only those areas that you're reporting on in NHSN. But it will pull in how large your facility is, how many beds. It gets down to that level within this report. The cloudy and cloudsy reports are pretty similar, then of course the C-diff one will only be by facility, backwide in. And this cloudy one, same thing, it goes down into, first it's the facility rank, and then each ranking, the location rank, within that ranks each of your units. And then with the C-diff one, that one is only going to be backwide in, of course, but we still get the ranking of the facilities within our network. We can actually help the facilities pull their own TAP report, or you can just contact us and we can pull it. We're working with Jennifer Chang, who many of you have met online when she's doing our quarterly data reports, to see what's going to be the most useful way for us to pull that report and get it out to our facilities and the people in the network. So more to come on that as we move forward. And just more examples. As with any other report, we have to keep in mind that whatever time period we put in there, when you can pull these reports, like with Cloudy, it'll go back to 2012, I think. Of course, we don't want to pull them back that far, but whenever you do get these reports or you pull them, you have to make sure that you're putting in the dates that you would want to, and then the locations and any other factors with the analysis. So any questions about that so far? How does everybody feel about the TAP strategy and the CAD?
So, will Linda speak up again and explain how CAD is different than SIR? I like the way you said that, and I need to get this into my head because this is the first time I'm hearing of it.
And are you talking about Carol?
I thought it was Linda spoke of. Someone came in, I'm sorry, whoever it was, came in and explained the conversation that you had about the difference between CAD and SIR. Can you explain that again?
Yes, that was Carol and I, so I'll let Carol chime in. That's fine.
Okay, great. Yeah, so Deb, if you back up a couple of slides to that CAD definition, I think it's in that, let's see how it in this one, right there. I think that's the one. There may be another slide actually that actually says difference in there. But when you're looking at the third definition, the observed over the expected, when you look at that definition and you look at the CAD, if you're not careful, you think, well, what's the difference? Are these seem the same? But the CAD is actually the difference, the number that is the difference between observed and expected. So that's how you get the over or under number. So it's
either going to be a positive number or a negative, and if it's negative, it's below.
Yeah, you have less than expected, correct. And if it's over positive number, then it's more than expected.
Okay, thank you.
Yeah, and then you can actually see how many you need to reduce it by. Now, the observed is still being calculated on the current SIR. Just the way the current SIR is being calculated. So moving forward in 2016, of course, we're going to be using the newer calculations and the newer baseline of 2015. So these will change some moving forward, just the number, but for right now, this is, what we have to go on. I'd also like to call out Andrea. Do you have any other information you wanted to share about this?
Not at this time. I think you all are doing a good job with it.
Thank you. Well, and that being said, when we're doing our onboarding calls and moving forward, there's a whole assessment that goes with this. I think it's, 6, 8 pages of assessment. Some of you have already seen this. Some of the hospitals have done this assessment to give us some feedback on it. But we'll be sharing this baseline assessment tool with the hospitals, working with you with the TAP report to target the units in each of your hospitals where you need the most help. And this tool has been created over the last couple years by a pilot with other QINs like Virginia or like VHQC in the last scope of work. And this is what they came up with. So it's been used and targeted and changed, and it's a pretty good assessment. We've gotten really positive feedback from it. The idea with this assessment is that it is completed by different staff levels on each unit. And then there is a database that all of this information gets plugged into so that you will get data back to the unit level on the gaps in your program and the gaps in education or learning per level, like which level of staff needs a little bit more education on which areas. So this is exciting. It's part of our contract with CMS to use this. So moving forward, you all are going to hear quite a bit about this. Any questions?
Yeah, one thing I wanted to say, whenever we were in the recruitment phase and we were talking to so many folks in our respective states about joining the project, many times, I got a question about what assessment tool what type of assessment were we going to use, how were we going to help them identify their gaps in best practice. Those types of questions came across during our recruitment phase. And so I was thrilled to be able to say, that we'll have this CDC validated tool on CAUTI's assessment, and then, we've mentioned before the opportunity that we're going to have to pilot a CDF tool as well. So we've got some great tools that are rolling out that are really going to help us not only to identify, where we need to focus our attention with the TAP report, but also once we've identified the area, we have a tool immediately ready to identify our gaps in our best practice process.
Yeah, thank you. All right, well, I am going to turn the call over to Carol at this point to finish up with the agenda. So, Carol, thank you.
Okay, well, great content today, everyone, and we know that the purpose of this call is for sharing, what's going on in our hospitals, what we're focusing on, what we're doing successfully, what some of our barriers are, and how we can really network with each other and share among ourselves on how we can do better care for our patients, safer care for our patients. So I think we have probably about maybe 6 minutes left to talk about that. And as we move along each month, Deb and I are really working hard. I know sometimes it might not seem like it, but we're really working hard to reserve this best sharing time. And we're really, our agenda should be tilting or shifting more to more sharing time and less announcements and events, event information. But we have to get our program up and going, and that just seems to be the way we have to do it at this point. So I'm just going to remind everyone to take a look at the agenda, look at the scheduled events, all the tool locations for the CAUTI test, ICU, that has all been moved over to the HRQ website. Please register for the land call on November the 3rd. Deb, I think, had personal experiences. She waited a little late last time to register, and they were out of line. So it's a national call. We have over 400 people on that call last time. So go ahead and get registered for that early. And then, of course, the online community updates and the resources and tools. There's a great cost calculator if they're trying to show your leadership the cost of these HAIs and trying to justify additional resources. That's a great tool to use. There's a good article out there on antimicrobial stewardship. And then, of course, I want to remind everybody, if you have not already, please go and view the recording of the BAE education. More coming on that later. You're going to be glad you did, and let us know your thoughts around that. So that's to our sharing, open forum now. We want to turn this over to you guys, and so that you may have something really exciting that you want to share that you've, particularly accomplished maybe with your teams, or maybe you're re-engaging your teams, what's going on with nursing. Where would you guys, I think the first question maybe we ought to start it off with so we can kind of focus a little bit is, where are you planning to focus your efforts around HAI work the last quarter of this year, maybe the first quarter of next year? Claudia, Clancy, CBS. Love to hear from you guys on that. The lines are open, so just jump in.
This is Susanna, Pennsylvania, and we're focusing on trying to get focus on the reasons that Foley catheters are in place and trying to get nurses engaged in getting those catheters out when there's no need. And what I'm finding is really the lack of understanding of the reasons for Foley catheters, and the biggest challenge being when they need urinary output measurement. That it really doesn't align or doesn't seem to align, and someone else might have a comment on this when CDC says that you have to have hourly strict I's and O's to be a reason for it to be in. And a lot of times we'll have patients, a lot of our patients who are getting LASIK, but they're on a regular floor, and they're urinating a lot. And so a lot of times the nurse and the patient wants to have that Foley catheter in place because they would be getting up so much to go to the bathroom because there's just so much output. And I just wondered if this has ever come up, because this is kind of one of the typical patients that it's hard to get that Foley catheter out of.
This is Cindy Roberts, and I'm calling from the Medical Center. We're having the exact same thing. I have been able to reduce my clotty rate, but I haven't really been able to move those device days a whole lot down, and so that's going to be my focus, try to get rid of, reduce my Foley device days for the coming year. But that is one of the comments that I receive as well, trying to get rid of them.
Okay, have I heard anybody on the call that's had any success in this area that you'd like to share?
Hi, it's Patty from Exeter St. Mary's.
Hi, Patty.
Hi. So just to share with you, what we started doing is that we actually have a nursing protocol now to actually withdraw the urinary catheters. And this has truly helped. This has given a lot of education to the nurses on when it actually is appropriate to withdraw the indwelling Foley, as well as actually cut down the amount of phone calls that the primary physician is receiving.
Can you share that protocol?
Absolutely.
Are you on the online network? Yes, the online community for VHQC. Can you try putting it on there? And if you have any problems with it, give us a call.
Absolutely.
We want to start using, and then also send it to us because there are a few of our providers who can't get onto the community.
Okay, very good.
Anybody else have anything else that they would like to share around the process of getting those Foleys out that they've been successful with? Anything maybe in addition to the nursing protocol or their nursing protocol? One thing I'll say about the nursing protocol, it's heavily involved nursing leadership to get that launched and to get it approved and then get it implemented. What I found occasionally is that the leadership will do a really good job of getting the protocol implemented. But it's a change in nursing practice for a lot of nurses. Just like, when we try to change physician practice, sometimes we don't really realize how difficult it is for nurses to take on a protocol like that. Sometimes they shy away from that. They're afraid of it. They're not sure. And so they feel a bit of fear going into a new protocol like that. So lots of education, lots of leadership support around implementation of a nursing protocol is extremely important for it to be successful. Patty, did you guys have anything, did you guys experience anything around that?
Absolutely. And so one of the things that I did is being the IP, I went daily. When I do my daily rounds, I look at all of the Foley's, and then I would take the nurse and we would look at the protocol and go through it together. And then I would actually call the physician with her. Just if she was really adamant on calling the physician, just let them know this is what we're doing. We're taking out the Foley and this is why. Because they felt that they truly needed the doctor's support. So, and there was also education with the physicians of this is what we were truly doing. And it took a lot of collaboration, but definitely a lot of leadership support.
Yeah, a big culture change. So
it truly is.
Yeah, and great work. And thank you for sharing. You guys, we're a little bit over now. We've gone over the top of the hour. Many of you hung with us. We still have 44 on the call, so we know that the sharing time is especially important, and again, we'll work very hard to continue to add more time to that each month. Do you have anything else to wrap up?
Well, I just want to encourage everybody to continue this discussion on the online community. It's something that we're all really new to, so this is the type of thing that we can go back and forth with and discuss on there. So thank you all, and we will be talking to you during the month and then again next month on the sharing call. Thank you.
Happy fall, everyone.
Thank you.
Bye-bye.
Bye-bye.
Thanks, Deb. Thanks, Carol. Great job.
Oh, thanks a lot.
Welcome. Thank you, guys.